I want to begin today with something that most caregiving resources don't say directly enough. If you are caring for someone in the later stages of Alzheimer's disease, you are doing one of the most demanding things one human being can do for another. Not figuratively, literally. The physical demands are real. The emotional weight is real. The grief of watching someone you love move through the final stages of a disease that has already taken so much, that grief is real too. And it doesn't wait for the end. I also want to say something that I think is equally important. The care you provide in this stage matters profoundly. Not because the person will remember it. Not because anyone outside your immediate situation will fully understand what you're doing. But because the experience of comfort, dignity, and presence that your care creates, that experience is real for the person you're caring for, even now. Even in the later stages. Today, we're drawing from the National Institute on Aging's guidance on care in the last stages of Alzheimer's disease. It's detailed, specific, and written for people who are in the middle of this, not preparing for it in the abstract, but living it right now. And there's something within this guidance that I want to build toward today. Something about pain in late-stage Alzheimer's that most caregivers don't know how to recognize, because the person can no longer tell them in words. Understanding this changes how you read what you're seeing and how you respond to it. Stay with me. Let's start with physical mobility, because as Alzheimer's progresses into its later stages, movement, the ability to get up, to reposition, to walk, becomes increasingly limited and eventually impossible for many people. This is where many caregivers first realize they need professional guidance, and the NIA's message on this is clear. Ask for a referral. A physical therapist, an occupational therapist, a home health aide, or a nurse can come to your home and teach you specifically how to move the person safely, how to help them change position in bed or in a chair, how to transfer them from one surface to another without hurting them or yourself. This is not optional knowledge. It's essential knowledge, and trying to figure it out by instinct, without training, risks injury to both of you. One specific technique worth knowing is called range of motion exercises. When someone is no longer moving independently, their joints can stiffen and their muscles can contract. Range of motion work involves gently holding the person's arms or legs, one at a time, and moving and bending them through their natural range of motion several times a day. This prevents stiffness, it improves circulation, and it helps prevent pressure sores, painful open wounds that can develop when a person remains in one position too long. The NIA recommends repositioning someone who is sitting up at least every 2 hours, and someone lying down at least every hour. Your own body matters in this equation too. The guidance on lifting and moving is specific about caregiver safety. Bend at the knees and use your thigh muscles, not your back, to lift. Keep your back straight. Hold the person close to your body rather than reaching away from you. Take small steps when transferring from one seat to another, and never twist your body during a transfer. These mechanics are not overcautious. Back injuries sustained in caregiving are common and serious. Protecting your physical health is not separate from your ability to provide care. It is the foundation of it. Let's talk about eating and nutrition, because this is an area where late-stage Alzheimer's caregiving involves challenges that most people aren't prepared for, and where the right techniques make a real difference to both comfort and safety. People with Alzheimer's often lose interest in food as the disease progresses. This can start in earlier stages and intensify over time. In the later stages, it's common for the person to eat much less than they used to, and sometimes to resist eating altogether. Here's where most people get it wrong about eating with late-stage Alzheimer's. They try to replicate the normal mealtime experience, a full plate, sitting across from each other, eating in familiar portions and rhythms. And when the person doesn't cooperate with that structure, the mealtime becomes a source of frustration and distress for both of them. The adaptations that work are specific. Give small amounts of food at a time, not a full plate that can feel overwhelming. Sit beside the person rather than across from them. Sitting directly in front can feel confrontational or intimidating. Describe what they're eating as you offer it. The sensory cue of naming the food helps orient the person to the experience. Encourage the person to feed themselves as much as possible. Even partial self-feeding preserves dignity and engagement. And be patient with the pace. Rushing mealtimes is one of the most common sources of mealtime difficulty. When someone eats very little, high-calorie, nutritionally dense options become more important. Protein milkshakes, foods prepared with healthy fats, foods that deliver substantial nutrition in small quantities. If caloric intake becomes a serious concern, the person's doctor should be involved. They can advise on dietary supplements and other strategies. Swallowing deserves specific, careful attention. In the later stages of Alzheimer's, the ability to chew and swallow safely often diminishes. And this matters enormously, because when food goes into the lungs instead of the stomach, a risk that increases with swallowing difficulty, it can cause pneumonia. This is a serious, potentially fatal complication. The NIA's guidance on managing swallowing difficulty is specific. Cut food into very small pieces. Offer soft foods, yogurt, applesauce, mashed avocado, sweet potatoes, bananas. Avoid straws, which can actually worsen swallowing problems. Instead, offer small sips from a cup. Try different temperatures of liquid, warm, cold, room temperature, to find what the person swallows most easily. Never feed a person who is drowsy or lying down. They should be sitting upright during the meal and remain upright for at least 20 minutes afterward. And give them time. Say swallow gently as a verbal cue if the person needs reminding. If you observe signs of swallowing difficulty, coughing during meals, wet-sounding voice after eating, food seeming to stick, tell the doctor promptly. A swallowing evaluation can identify the specific nature of the problem and provide more targeted guidance. Let's talk about skin care and pressure sores, because this is one of the most common and preventable complications in late-stage immobility, and one of the most important areas where caregiver knowledge makes a direct difference to the person's comfort. When someone stays in one position for extended periods, the weight of their body against the surface they're resting on creates sustained pressure on the skin and underlying tissue. Over time, this pressure reduces blood flow, and the skin begins to break down. The result is a pressure sore, painful, difficult to treat, and sometimes dangerously prone to infection. The earliest sign is discoloration, the skin getting darker or reddened in a specific area. Watch carefully for these early signs, particularly on the heels, hips, lower back, and back of the head, the areas that bear the most weight when someone is lying down or sitting. Prevention is far better than treatment. Repositioning everyone to 2 hours is the foundation. Pressure-relieving mattress pads, filled with foam, gel, air, or water, distribute weight more evenly and reduce the concentration of pressure on any single area. Barrier creams and ointments keep skin clean and protected. Gentle massage with unscented lotion supports circulation and provides physical comfort. Lip balm for dry lips. Eye cream around the eyes. Damp cloths for dry eyes. These small, specific acts of physical care are not small in their effect on comfort and dignity. Foot care is also important and sometimes overlooked. Soaking feet in warm water, gentle washing, moisturizing, and checking for any sores or skin breakdown, particularly important for people with diabetes, who are more susceptible to foot complications. A podiatrist can be a valuable resource for this specific aspect of care. Now, I want to address something that happens in later stage Alzheimer's that can be alarming and confusing for caregivers who haven't been warned about it. It's called myoclonus. This is the sudden jerking or spasming of the arms, legs, or whole body that some people develop in advanced Alzheimer's. It can look frightening. It can look like a seizure. And if you haven't been told it's a possibility, the first time it happens can be terrifying. The important distinction, as the NIA explains, is that myoclonus doesn't typically cause the person to lose consciousness, which distinguishes it from a true seizure. If you observe signs of myoclonus, tell the doctor right away. There are medications that can help reduce the symptoms. This is not something to manage alone or to wait and see about. It's a medical development that warrants prompt clinical attention. This is why doctors rarely explain this clearly in advance. These later stage complications, myoclonus, swallowing changes, specific skin vulnerabilities, aren't always covered proactively in earlier conversations about Alzheimer's progression. Families encounter them without preparation. and that lack of preparation amplifies an already difficult situation. Knowing these possibilities exist, knowing what to watch for, and knowing when to call the doctor, this is the kind of information that doesn't eliminate the hardship, but allows you to navigate it with more clarity and confidence. We're now at the section of today's video I've been building toward. And I want to tell you directly, what I'm about to share is the most important thing in today's video for people actively caring for someone in later stage Alzheimer's. It's about pain. Specifically, how to recognize pain in someone who can no longer tell you they're hurting. In the final stages of Alzheimer's, verbal communication is often significantly reduced or lost entirely. The person cannot say, "I'm in pain." They cannot point to where it hurts. They cannot describe the quality or intensity of what they're experiencing, but they can show you. And learning to read those signals is one of the most important skills late-stage caregiving requires. The NIA's guidance is specific. A person with advanced Alzheimer's who is in pain may express it through groans or sighs, sounds that aren't words, but carry clear distress signals. They may grimace when touched or when moved. They may become agitated, upset, or even aggressive, behaviors that can easily be misread as personality symptoms of the disease rather than responses to physical discomfort. And they may sit or position their body in unusual ways, guarding the part that hurts. If you observe any of these signs, and you think pain might be the cause, tell the healthcare team immediately. Don't wait. Don't try to determine on your own whether what you're seeing is pain or something else. Bring it to the clinical team. There are pain medications and non-medication strategies that can address late-stage pain effectively, but they can only be deployed if the team knows that pain is present. This is the information that I most want caregivers to take from today. Because a person in pain who cannot tell you they're hurting is in a uniquely vulnerable position. Their only advocate is you. And your ability to read the signals, to notice the grimace, to hear the quality of the sigh, to recognize that unusual positioning might be a pain response rather than random movement, that ability is a form of profound care. You are their voice when they've lost their own. That is an extraordinary responsibility. And you are doing it. Let's talk about end-of-life care, because while this is the most difficult section of today's video, it's also among the most important. Planning for the end of a person's life and understanding what to expect can genuinely make this time easier for everyone. Not easier in the sense that it removes the grief or the difficulty, but easier in the sense that clarity allows for presence. When you know what is happening and what to expect next, you spend less energy in confusion and fear, and more energy in being with the person you love. The NIA specifically recommends hospice and palliative care programs as resources for coordinating late-stage and end-of-life care. Hospice provides specialized, comfort-focused care for people in the final stage of a terminal illness. It provides not just medical support, but also emotional and spiritual support for the person with Alzheimer's and for their caregivers and family. If you haven't yet had a conversation with the person's healthcare team about hospice and the disease is in its later stages, that conversation is worth initiating. Many families wait too long. Hospice support, introduced earlier, can meaningfully improve quality of life in the final months and provide caregiver support that many families desperately need and rarely ask for soon enough. Even in the most advanced stages of dementia, connection remains possible. The NIA's guidance is both compassionate and clear about this. Your physical presence can be calming. Touch, a hand held, a gentle massage, can provide comfort even when verbal communication is no longer possible. Music, white noise, or nature sounds can reduce agitation and create a more peaceful environment. Showing photographs, telling stories, being in the room, all of these offer a form of presence that reaches the person even when they can no longer respond in recognizable ways. Just being there is not nothing. It is, in many ways, everything. Before we move to practical actions, I want to address something directly, because if you've been in this caregiving role for any period of time, you've experienced it. The emotions that come with caring for someone through the later stages of Alzheimer's are complicated. They are layered in ways that can feel contradictory and even shameful. Sadness, exhaustion that goes beyond physical tiredness, moments of profound love, moments of grief that arrive before the end. and sometimes moments of something that feels like relief mixed with guilt for feeling it. The NIA's guidance acknowledges this directly. When a person with Alzheimer's dies, caregivers can experience a range of emotions: sadness, loss of purpose, guilt, and relief. And it says clearly, these feelings are normal. Relief is normal. It doesn't mean you didn't love them. It means you've been through something extraordinarily hard and sustained, and part of you recognizes that their suffering, and yours, has ended. That is a human response. It deserves compassion, not judgment. Whatever you feel in this chapter, before the end and after, is a legitimate emotional response to an experience that most people cannot fully imagine unless they've lived it. Please treat yourself with the same care and tenderness you've been giving to someone else. Let's bring everything together with practical actions. The first is to ask for professional training in safe movement and transfer techniques. Contact the person's doctor for a referral to a physical or occupational therapist who can come to your home. This is not an indulgence. It is a safety necessity for both of you. Learn proper body mechanics before you need them urgently. The second is to implement a consistent repositioning schedule and invest in pressure-relieving equipment. A specialized mattress pad, regular 2-hour repositioning when sitting and hourly when lying down, and daily skin checks for early pressure sore signs. Catch these early. The cost of prevention is far lower, in comfort, in time, in medical complexity, than the cost of treatment. The third is to learn the signs of pain in a nonverbal person and take action when you see them. Groaning, grimacing when touched or moved, unusual body positioning, unexplained agitation. If you observe these signs and suspect pain, contact the healthcare team. Don't wait. Don't rationalize. Advocate for pain assessment and management as a non-negotiable element of late-stage care. The fourth is to initiate the hospice conversation if you haven't already. Ask the person's doctor directly, is it time to talk about hospice? If the answer is yes or maybe, have that conversation fully. Hospice is not giving up. It is choosing comfort and dignity and support over interventions that are no longer serving the person's quality of life. And the fifth is to seek support for yourself, consistently and without guilt. A social worker, a counselor, a caregiver support group, respite care that gives you genuine time away. The Alzheimer's Association at 800-272-3900 has resources for caregivers, including support groups and a 24-hour helpline. You cannot sustain this role depleted. Seeking support is not abandonment. It is wisdom. Here's what I want you to carry with you from today. The later stages of Alzheimer's are hard, among the hardest things a family can go through. And the guidance that exists, detailed, practical, specific, is meant to help you navigate those stages with more knowledge, more skill, and more confidence than you'd have without it. The person in your care can no longer tell you what they need in the way they once could. But your presence, your attentiveness, your willingness to learn and to adapt, these reach them in ways that matter. Comfort matters. Dignity matters. The quality of the environment you create around them matters. You are doing something that requires everything. Your love, your patience, your physical strength, your emotional resilience, your willingness to face things that are profoundly hard. Please don't do it alone. Please accept the support that exists. Please honor yourself for what you are carrying. What you are doing matters. You matter, and you deserve to know that. Before you go, I want to plant something important in your mind. We've talked throughout this series about caring for someone with Alzheimer's, from early stage through the final stages. But there's a dimension of this experience that almost never gets its own focused, honest conversation. It's what happens to caregivers after. After the caregiving ends, the identity loss, the physical recovery, the complicated grief, the disorientation of a life that was consumed by a role that suddenly no longer exists. The research on caregiver grief after Alzheimer's is specific and important, and the support that exists for this particular kind of loss is more accessible than most people realize. We'll explore that next. And if you want to be there, if you want to keep getting honest, compassionate, research-grounded guidance on every stage of this journey, subscribe to this channel. Take very good care of yourself. What you are doing is extraordinary, and you don't have to do it alone.